his experience, his engagement into artificial intelligence, and the challenges he can see for all of this. Alexandre, the floor is yours. Happy to welcome you, and thank you so much for being available with us today.
So thank you so much. Can you see my slides?
Yes, indeed, we can, Alexandre.
Okay, so thank you very much for welcoming me into the GIANT session. I will try to give a quite short overview of the French version of AI in healthcare, and especially coming from a specialist in intensive care and anesthesiology, which I am, working in the University of Paris and into Bichat Hospital. So, as you're aware, human and artificial intelligence combines their strength to give to clinicians who are becoming augmented professionals, but also to the health systems to improve workflow, and to the patients who are consumers and now involved into the P4 medicine, personalized, predictive, preventive, and participative, to use big and smart data and increasing computing power, including the possibility to store all this data on the cloud, and developing accurate algorithm which can increase productivity, workflow, especially starting from use cases and very interesting real-world use cases, avoiding bias, being transparent, and dealing with the privacy and security problems in order to limit errors, non-quality healthcare, decrease waste, costs, and give us more time. All of this for the need or more ethics and humanism for doctors. So, as you're aware, there is a huge increase in data coming from genome, proteome, epigenome, transcriptome, phenome, and also social media. And for instance, healthcare data collections have been doubling every 4 years in 2010, and now doubling every 75 days. And this is also a good thing that we now dispose from wearable technologies, including in the hospital, to develop remote and telemonitoring. So as you're aware, the first results about AI in healthcare were produced in the 2017 with 2 Princeps papers. The first one was the one developing retinal fundus photographs AI-enabled possibility to use them and to analyze them with the AI algorithm. And FDA nowadays has given approval for autonomous detection of retinopathy without the need for clinicians in the United States. The second possibility was devoted to dermatology, and in fact, using more than 100,000 photographic and dermoscopic digitized images, several board-certified dermatologists were at least matched in performance by the algorithm, with an accuracy of more than 0.9 for carcinoma and melanoma. So there is a wide variety of algorithms now developed, and all of them ranging from specialty doctors to paramedic, and they will be used for AI. In almost all fields of radiology, MRI, US, and you've seen here CT scans of the head, it has been developed, and algorithms perform better than radiologists, achieve a level of accuracy better than several of them, and most important is 100 times faster, 24 out 24, 7 out 7 days. And this allows remote monitoring, analysis, and time saving. And I've listed here a very smart review from Eric Topol in the Nature paper, where he summarized all what is currently possible and has been developed as AI algorithm compared with doctors in the field of radiology, pathology, dermatology, ophthalmology, gastroenterology, and several others, with very good accuracy and very interesting results. This paper is also very interesting. It's a paper coming from United States, from the Mount Sinai Hospital, where they took more than 70,000 electronic health record from patients And using this deep learning solution with hidden neurons and CNN, convolutional networks, neural networks, they could predict what would be the diagnosis and what would be the development of such diseases like diabetes or congestive heart failure or even schizophrenia. So now I will speak about AI in my own activity and in my Indeed office. And as you can see, as an anesthesiologist, I'm using several machines and also information about the patients coming from biology, X-rays, radiology, and any others data, which makes the OR and also the intensive care one place where you will collect almost the most important data every second about the patient. And in fact, in this specialty, there has been a lot of papers and studying demonstrating the use of AI to first predict postoperative in-hospital mortality, or to characterize and also develop new way to detect and prevent and also take care of cardiac arrest into hospitals. And most recently, there have been a lot of papers demonstrating the role of AI-enabled electrocardiograms analysis to detect, for instance, arrhythmia, or also low ejection fraction of the left ventricle. And this is extremely interesting for our practice. In the field of anesthesiology and intensive care, there have been also a lot of papers in the most important journals here, Nature, developing the prevention of hypoxemia during surgery algorithm, or here one paper about sepsis, which is infection in intensive care, and in which artificial intelligence clinician, we call it AI clinician 2.0, can learn about optimal treatment strategies, either volume, for instance, or vasoactive agents for hypertension, which is a quite common situation in my world. Very recently, we have been looking at the way to predict and to avoid hypertension very quickly, because you're not as an anesthesiologist. There is a relationship between myocardial injury during surgery and the importance of hypertension and the time. And what is very, very important is to detect it before hypertension occurs in order to avoid myocardial injury. And this a nice JAMA paper recently published demonstrated that adults scheduled for elective non-cardiac surgery were randomized to either this AI early warning system or the standard sensor. And it was able to decrease the time average of hypertension by the use of this early warning system with a very good accuracy. So this is some examples of my own practice around the development of early warning scores. Here is the blood pressure, oxygen saturation, heart rate. And you see here, the nurses are working alone because I gave them a protocol to increase blood pressure using vasoactive agents, using blood pump, syringe pump, infusion pump. And at this time, I'm not on call, I am in my office, and several things occur. Heart rate increases, oxygen saturation decreases, and also blood pressure currently decreases. And at this time, they call me, but very late in the intervention. And if I could see that here is happening something, it could be very interesting for me to be there rather than there to take care of the patient. This is another example of an interpretable machine learning model for acute prediction of sepsis. This is a patient undergoing surgery, digestive surgery, and you see here the days. And during this period, everything is okay. You see here the vital signs, and you see here the algorithms. Several of them developed to detect that something is going wrong and there is a worsening of the patient. And here he develops fever, he's increasing his heart rate, decreasing his blood pressure, something is happening. But I can't see with my own eyes whether at the same time the algorithm tell me there is a big problem. And indeed, one day later, the patient developed peritonitis. And the point is that before we see that the vital signs in a multi-parametric vision are indicating a worsening of the patient, this algorithm allows us to see it earlier. And this is the concept of early warning scores. And we can go further because this is a very, very interesting paper developed in emergency departments in California and published in Nature Digital Medicine. Regarding more than 200,000 electronic heart health record from the emergency departments of California. Look at here the patient admitted to hospital. So we are integrating a lot of data coming from biology, data coming from physician note and so on, radiology, biology, surgery. And finally, you can see here that several days later, so it means at least 24 hours after admission, the algorithm is able to predict the risk of inpatient mortality. And indeed, this patient dies 10 days later. So this is very impressive. And once again, this is the review from Eric Topol in the Nature journal, where you can see that this paper was able to accurately predict in-hospital mortality. And there are several others of them predicting all cause of months mortality, or also several conditions, readmission, sepsis, septic shock, and so on. So in my own hospital, we are trying to implement this kind of algorithm. It means that we need to have a data collection and curation. And this is using a lot of text, which is critical even in the ICU. Otherwise, data that are currently not captured, procedures, patient state, medication, episodic measurement, and so on, have to be recorded in order to implement good algorithm. And then try to use it and try it on use cases. And you have to decide which one you are going to use. This means that you are collaborating there is good collaboration between your clinicians and your data scientists and also engineers. And afterwards, you have to validate your algorithm into randomized control study, and it will take a lot of time. And finally, you have to implement it in clinical practice, and this is not a simple task. So indeed, is it hype or hope? The hope is that we improve diagnosis, prediction, quality of care, improve clinical decision-making, and deliver better patient pathway and improve patient compliance. So it means increase efficiency and as well decrease costs. And in order also to keep in mind that augmented healthcare professionals are still developing and even increase their capacity of empathy and humanism. However, are we now in the crossing the chasm to the development of AI, and are we in the decreasing part of the hype curve? It's possible, because it will take a lot of time to develop this algorithm and also to test them and to introduce them into randomized clinical trials of artificial intelligence, and comparing what are the evaluation of drug candidates that will take a lot of time before being approved. It's very possible that algorithm candidates also have to pass through these different steps in order to be validated and to have approval from different administration and authorization systems. So in fact, I will finish by 2 or 3 limitations and challenges. First, at least in my specialty, we've got a lot of unstructured data, and we've got also a lot of non-validated or not robust data, and as you garbage out for the algorithm. So lack of data, too much of demonstrated what is behind these neural networks and what is indeed the black box behind it. Finally, accuracy is a good point, but it's not always clinical efficacy. And it will have to be accountable for the medical legal impact and the liability problem for doctors as well as for hospitals. So, and last but not least, privacy, security, and ethics is a big and major problem. And don't forget that especially in this COVID period, we have been dealing with a lot of problem with burnout doctors, a kind of big difficulty to finance, at least in France, hospitals. And this is a French cartoon indicated that hospital may be out of order. And it's a big issue. So to conclude these limitations and challenge, before going from algorithm, publish them, then being approved, and then going into real world healthcare, there are a lot of problems, but some solutions to deal with these problems. First, data availability and quality, exhaustiveness, but also IT systems that are not very well developed, at least in French hospitals. And this means developed hospital warehouse and even national health data hubs. Second is lack of skills and poor confidence into AI. it means that medical and healthcare professionals and doctors will have to be educated and trained in this new field of medicine, and that will have to be convinced about the black box behind the algorithm. Third is the necessity or the need for a very good collaboration between clinicians and scientists to develop a smart algorithm in thinking big, but smarting small, develop important and relevant use cases and scaling fast. Ethics and privacy, of course, and maybe the role of trusted third party will be important. And finally, giving budget and management input. And this is not very easy, especially because this kinds of system needs a real and validate business model. So finally, my conclusion will be, you've got with AI a lot of solution coming from early stage of life to the end of it. And you've seen some of them here: assist and reading scans, prevent blindness, classified patients, promotes patient safety, and then predict the occurrence of many diseases and even death. And to do that, we need to have AI strategy, maturity and application of AI, operating model, which means organization, internal process. We have to also to deal with limits and ethics, and finally to make technological choices to build algorithms and to make them available, robust, and usable for clinical practice. So thank you very much for your attention.